So I'm sort of doing a similar talk as Dr. Sethi, and that is I'm focusing on the hip joint, but how can we avoid, however much we love Dr. Ennis and Dr. Kavanagh, how can we avoid sending our patients to them, particularly younger patients who may not be at the point where they need a hip replacement or a knee replacement, but I'm really focusing on the hip in this talk. So when a patient comes in presenting with hip pain, particularly the younger patient, the athlete, where is the hip pain? That's really the first thing we need to assess, and probably before that we need to say, is this coming from the hip itself or is it coming from the back? But kind of narrowing it down to the hip, is it in the back, is it on the side, or is it in the groin? If the patient presents with hip pain in the back, that's where you really have to, in the back of the hip joint, that's where you really have to think, is this coming from the back itself, not from the hip joint? The hip joint is a ball and socket, and that joint is really in the front. It's right in the groin. So if someone is complaining that their pain is in the back, that's likely not coming from the hip joint, but coming from some of the other joints in the area. The sacroiliac joint, the lumbar spine, or the piriformis, which is a muscle in the buttock that can cause pain. If they're having pain more on the outside of the hip, a lot of patients come in and say, I have a problem with my hip, but it's really on the outside. That's often bursitis or tendinitis, and that can be treated in a different way. And then if the patient comes in with groin pain, and that's really where the hip joint is itself, we need to think about a sports hernia, other tendinitis, things like osteitis pubis, hip flexor tendinitis, again in the front of the joint, but not necessarily in the groin or in the joint itself. And then finally, we need to look at the hip joint itself. So when we narrow it down, we've now narrowed it down to the hip joint. We know that this patient is presenting with hip pain that's consistent more with the groin, with the hip joint itself, not outside of the hip. What are the things we may consider? The first would be AVN, and that means that the head of the femur, so that ball and socket joint, that head may have actually died, some of that tissue may have died, so that it's collapsing, that bone is collapsing. The second can be trauma. The third can be a stress fracture. We see a fair amount of stress fractures in the neck within the of that femur that can cause pain within the groin. And then the fourth thing here would be arthritis, and that's fairly common, and Dr. Ennis will talk about that further. And then the last thing, which I'm really going to focus in on now, is called impingement in the hip, and that's the big term for it is femoral acetabular impingement, and what that means is that there's impingement between the ball and the socket, and I'll go on and show you a little bit more. So this picture shows the ball and socket, and we'll look at that in further detail. Okay, so here's a diagram showing the hip joint, and this is a patient who is pinching that ball and socket. So you can imagine when you roll around, if you have too much bone on either side, either on the socket or on the hip itself, you can pinch as you're moving around. The hip joint allows for a lot of motion, but if there's too much bone on either side, that can cause impingement. What that does is, as a result, is it causes both compressive and shear stresses between the cartilage inside the socket and on the ball, as well as the labrum. Now the labrum we haven't talked about, but it's really a rim of tissue that goes around the socket of the hip joint, and that helps to stabilize the joint. And so you can get injuries to the cartilage, which is similar to the knee. There's cartilage lining the bone, and then there's this cartilage that's like the meniscus that's around the edge, and you can get injury to both of those. So up here on the top left, what we see is a normal joint. So you can see this is the ball, and this is the socket, and these little triangles on the top and bottom are the labrum. You can, again, as I talked about, we can have too much bone on one side or the other. If you have too much bone on the cup side, on the acetabulum, that's called a pincer lesion. If you have too much bone on the femur side or the ball side, that's really on the neck, and that's called a cam lesion. And you can often have too much bone on both sides, okay? So what happens if you have a cam lesion? That's where there's too much bone right on the ball here. Normally you can see on this side we see a nice circle that goes around, and we'd like to see that same diameter come in here, but we're not. We're seeing this bump here. And what happens? Well, this causes compression and shear stresses, as we talked about. The labrum, which is right here, can get stretched out, and the cartilage on the inside can get compressed. this results in is basically separation of the labrum and the cartilage, and that can cause tears and then injury to the cartilage itself. What happens if you have too much tissue on the cup side, too much bone on the cup side? Again, the labrum can be compressed between the two, okay? And then you're repeatedly causing trauma to that labrum as the ball is hitting it, and that can cause actual ossification or bone that forms within that labrum. And this can cause injury to the cartilage on the outside as well. When we look at impingement, I talked about on the ball side, the socket side, and then combined, you can see that most people fall into that mixed category. Okay, so they have a little bit of both. You can see that about 16% fall on the cam lesion side, that's on the ball or the neck, and about 5% fall on just the socket itself, or just the acetabulum. So what causes this? If it's on the cam side where there's too much bone on the head or the neck, this can be from injuries to the growth plate. Usually in a pediatric population, they can have an injury that can be missed, or just the consequences of that injury itself can develop in time. If you have an injury or too much bone on the socket side, the acetabulum, the pincer lesion, that can be from basically they have too deep of a socket, so that's their anatomy, the patient's anatomy leads to that. It can also be because there's a little bit of a posterior tilt on the hip, which means it's facing backward a little bit, and that causes a little bit too much stress there in bone. So how do we further examine? Now we've narrowed it down to the hip joint. It's not on the outside, it's not on the back, it's in the groin itself. How do we really isolate it to impingement of the hip? You can have impingement both in the front and the back. This picture here shows, on the left, where we bring the hip up, and we call this into flexion, internal rotation and adduction, and that's really pinching that front part of the hip here. If we want to look at impingement in the back of the hip, you're going to drop the leg back down, and that's going to cause it to pinch in the back. You can imagine it's pinching right there in the back. So these are two physical exam findings that we utilize to help us determine where they're having impingement. The Faber test is another test that's very helpful, and it's traditionally used to look for symptoms coming from the SI joint. But if you do this with a patient, and that's where you put the patient's leg here with their ankle up on the opposite knee and bring them down. If they have decreased motion, or if they have pain within the groin, that also suggests that they can have injury to the hip joint or to some of the tendons in the front. Moving to the next step, we've isolated to the hip joint, we've done our physical exam, and now we want to look at x-rays and further diagnostic studies to see exactly what's going on with this patient. So this is an x-ray looking at the hip joint itself. And the important thing that we're going to look at right here, this is a picture basically of this x-ray, okay? So what we're looking at is these two lines here are very important in helping to look at the front and back of the socket. So the socket is a socket like this. You can imagine it has a front and a back wall, and it's a little rotated. So those two lines right here show the front and back. And what you can see on this x-ray is what's called a crossover sign. This is an X, okay? This right here is the back wall, the vertical one. This is the front wall. When you have too much on the front wall with that, it's turned a little bit and you have a little bit too much there, it crosses over. What we'd like to see is two lines that are more parallel to each other, and that's when we take off. I'll show you a little bit later. When we take off some of the bone here surgically, you'll see we recreate more parallel lines, so there's not that crossover sign. When there's too much bone on the head or on the bump, you can see here nicely there's this nice contour from the head into the neck. So you see on the top there's head, and there's no real dip into the neck. It just has this bump here. This again is, now we're moving to an MRI. The MRI can be very helpful in helping us look at the cartilage on the ends of the bone, the labrum, and also helping us look at this bump a little bit further. So the alpha angle is something we utilize to help measure. You can see in this situation, this is a normal hip. There's a good circle here. On this side, you can see this bump here that extends beyond that circle, and that extra bone there is what's going to hit. So again, the MRI can also help us look at labral tears. It can help us look at cysts that are associated with the pinching. what are some of the non-operative things that we can do? So a patient comes in, they haven't done anything for this. There are a lot of things that we can do before even considering surgery. So we can work on physical therapy that can help with strengthening a lot of the muscles around the core, and also helping the patient to understand what positions they should avoid so that they're not further injuring it themselves and causing symptoms. And then there's injections. The injections can help us both diagnostically, because we can do an MRI associated with that. If we do the injection with a steroid and a numbing medicine and the patient's pain completely goes away, we have a very good sense that their symptoms are coming from within the hip joint. If we do an injection, and Dr. Kessel does a great injection with fluoroscopic or ultrasound guidance, we know it was in the hip joint, but the patient has no relief of their symptoms, we have a good sense that their symptoms are probably not coming from the hip joint, because we put numbing medicine in there and it didn't help them. So that's very helpful for us to understand what's going on. And then the last step, after we've done all these things and the patient is still having symptoms, is to think about arthroscopic surgery. And what that does is it allows us to repair and preserve the cartilage within the joint so that the patient can hopefully delay further degenerative changes, so they don't have to go on and have a hip replacement, particularly at a young age. So this is a picture. This is the ball, and this is the socket. And what you're going to do is see how they're pinching as this hip is taken through a range of motion. I'm not sure why it's jumping there. Okay, so you can see I can't move the mouse, so I seem to jump. But right here, you can see it's pinching a little bit too much. The labrum is here. This is the ball, and you're going to see it pinching. Here, we're taking a probe within the hip joint. This is the socket. This is the labrum right here, and there's a tear of that labrum because of the impingement. And you can see that tear right in there where that probe can slip right in between the cartilage and between the labrum. This picture here is going to show us how we take that bump that's on the ball and smooth it down so that you don't have a bump anymore. You now have that nice contour between the head and the neck. So you're really just smoothing that out. And you can even imagine right here, as we're looking straight at it, that there's that curve that we didn't have before. And this is going back to the socket, where we're looking at trimming that pincer lesion. That's too much bone on the end of on the edge of the acetabulum or the socket, and we're trimming that off so that you don't have that overhang anymore. And this is the final step if a patient does have a tear in the labrum. This here, we're putting an anchor in. We're going to pass suture through that labrum and reattach it back down to the bone so it's not loose. So we're passing that suture, and you can see that labrum is separate right now, and it's going to come right down onto the socket. And this is the end of the case where we've already taken off the bump on both sides, and now you can see it's not pinching any longer as you're going through a range of motion. Okay, so here are the pictures that we were looking at before, and here's that bump right here, and you can see now after surgery we've gotten rid of that bump, so when this patient brings their hip up, they're not going to hit the bone on bone anymore. And this is that x-ray again that we're looking at the crossover sign, and that other picture was very obvious. This is a little more subtle, but now we're going to try to bring those lines back down together like this at the top, so you don't have that same overhang of bone. So which patients are really indicated or amenable to have hip arthroscopy? Not the patient with severe arthritis. They're probably not going to benefit from it. But it's the patient who has this femoral acetabular impingement, or FAI. If they have a tear of the labrum, injury to the cartilage, sometimes if there's laxity within the capsule, so they have a little bit too much motion, you can repair that. Loose bodies and other tendon-related injuries within the hip joint. This is traditionally what was done for some of these patients. Rather than doing a total hip replacement, we could do an open procedure where you go in and try to fix the labor and fix some of the other things. But you can see that doing this open surgery is far more invasive than the small little incisions that we use for the arthroscopy. So it's really a big step forward. So the take-home message is it's very effective, particularly for the young athletic population. It helps alleviate symptoms and really allows patients to go back to their activities of daily living, their work, and hopefully prevents them from developing further arthritis within the joint and prolongs their need for any further surgery like a total hip replacement. And that's all.